Hi everyone, I'm Dr. Roman and I'm a hematologist oncologist, and on today's video we are going to talk about kidney cancer, also known as renal cell carcinoma. And the reason I decided to make this video is because unfortunately I am seeing a lot of patients with this cancer. So I really thought that it would be prudent to make this video to help educate the public out there, because my goal with this video is to prepare you so that when you see your doctor, you know exactly what's going on and what questions to ask. So with that being said, let's get started. So my little medical disclaimer, this video is for educational purposes only. All right, so let's start off with a brief overview of everything we are going to cover. So we are going to go over anatomy, risk factors. Then we are going to cover staging. In other words, what do we do to try to figure out how advanced your cancer is? We're going to talk about the different types of renal cell carcinoma. Then we are going to touch up on genetic testing and who to test, treatment, then finally monitoring, okay? Now, before we move on, I'm going to recommend that you find yourself a piece of paper and a pen, because throughout this presentation, I am going to be telling you the questions that I would ask if I had kidney cancer. And let me remind you that I am a cancer doctor, and these would be the questions that I would have. So believe me, these are the questions that you need answered. So let's briefly go over the anatomy of the kidney, okay? So this right here is our kidney. And then sitting on top of the kidney, we have our adrenal gland. So this triangular shaped object on top of the kidney, that's an adrenal gland, which makes hormones. Then you know that our kidneys make our urine. As blood, see here in red, we have an artery. Artery brings blood into the kidney. Our kidney filters the blood, makes urine, and then blood returns to the body through our veins. That urine that our kidneys are making are going to go into our renal calyx, which are these structures that you see here, eventually making up our renal pelvis, and then finally our ureter, which is this conduit you see here, which will take urine into the bladder. And these green structures that you see here, these are our lymphatic vessels, okay? So these are lymph nodes, okay? Our body is full of lymph nodes, and you need to know this because cancer likes to go to these lymph nodes. So that's the reason you need to know this. Now, the last thing that I want you to remember is around our kidney, all around here, okay, our kidneys are surrounded by fat. That fat protects our kidney. And then around that fatty tissue layer, okay, we have a membrane that's called Gerota's fascia. And that fascia protects our kidneys. And you need to know this because when we get into the treatment and the staging aspect, I'm going to mention Gerota's fascia. So just remember, Gerota's fascia protects our kidneys. Our kidneys are inside of Gerota's fascia. Okay, so now let's move on. So now some basic facts about kidney cancer. First of all, kidney cancers are about 4% of all cancers in the US. I can tell you, unfortunately, I am seeing more and more kidney cancer as time goes on. The median age is around 64 years of age, and risk factors, in other words, things that can predispose you to developing kidney cancer, is smoking. I would say that's one of the biggest ones, obesity, hypertension, and chronic kidney disease. So example, if you have pre-existing kidney disease, this can also increase your chances of developing kidney cancer. And the last one would be a strong family history or genetics, okay? And the other thing that I want you to know is that about 70% of kidney cancers are detected or found incidentally. So for example, I see this all the time. A patient has a CT scan for some other reason, and lo and behold, they found that kidney mass, and then you were diagnosed with having a kidney cancer. So nope, you're not alone. 70% of the times, that is the scenario. So kidney cancer, as with all cancers, can spread to other sites of the body. And it's important that you know what are the preferred sites that kidney cancer likes to travel to. It's what we call metastasis. So the most common sites of metastatic disease in kidney cancer are the lungs, bone, the adrenal gland, which again, remember, it's that little gland sitting on top of the kidney, our liver, our brain, and that's right, lymph nodes, okay? There are other sites that kidney cancer can go to, but these are the more common places that kidney cancer can travel to. So these are the sites that we want to concentrate on when we are performing CT scans or, MRI scans. We want to try to focus on these sites, all right? So now this leads us to staging. And staging is basically tests that we are going to perform to try to figure out how advanced your kidney cancer is, okay? And for this, obviously, pictures of the body, what we call imaging tests, are the way to go. And the most commonly used is a CT scan or a CAT scan of the chest, abdomen, and pelvis with IV contrast if possible, or an MRI scan of the chest, abdomen, and pelvis with IV contrast called gadolinium. So if you can, contrast is very important on these imaging tests because these kidney cancers can really light up and you can see them. And they will give a characteristic appearance on imaging where a lot of times the radiologist, in other words, the doctor that reads these films, will tell you, you know what? That mass in the kidney is highly suspicious for a kidney cancer, also known as a renal cell carcinoma. The other test that we can consider is a bone scan. So if for whatever reason, let's say a CT scan or an MRI is inconclusive and we think you may have or suspect you may have bone metastasis, then we may perform a bone scan. Another test is an MRI of the brain because if you remember, we told you that kidney cancer can travel to the brain. So if you have a little more advanced kidney cancer, so it's a very large mass, for example, or let's say you have uncoordination or headaches, blurry vision, symptoms that may lead us to believe that you might have something in your brain, then we can consider an MRI scan of the brain. And again, with contrast if possible. The other tests that we commonly use in cancer, in oncology, are PET scans. So a PET scan is a test that uses glucose and a fluorescent molecule. So cancer likes to eat glucose, and if it does, it's bound to this fluorescent molecule and it'll light up, and a PET scan will detect cancer cells. It's a pretty decent test overall in oncology, but for renal cell carcinoma, it might not be as good as in other cancers. So that's why I put on here, PET scans are not commonly used. Sometimes we do, and maybe your doctor did in your case, but I just wanted to let you know that it's not one of the more common tests. Overall, a CT scan of the chest, abdomen, and pelvis with IV contrast is the test that we mostly perform. Now let's get into the individual stages of kidney cancer and what makes that kidney cancer that specific stage, okay? So kidney cancer is divided into 4 stages: stage 1, stage 2, stage 3, and stage 4. Just know that stage 1 is the earliest form of kidney cancer, whereas stage 4 is the most advanced. So let's go here to this picture, and starting on top, stage 1 kidney cancer means that you have a mass that is 7 centimeters or less in size, and that the tumor is confined to the kidney. So, for example, you may have a mass anywhere here in the kidney, okay? It's not invading anything else, and it's 7 centimeters or less. Stage 2 is the same thing. It's not invading anything around, but it's greater than 7 centimeters. Now, stage 3 is a little more advanced, okay? Stage 3 can mean, number 1, you may have regional lymph nodes. So remember the lymph nodes that I showed you on the anatomy portion? You may have some of those regional lymph nodes with cancer, or you may have involvement of blood vessels, again, those arteries and those veins coming in and out of the kidney, or the kidney cancer goes to the perinephric tissue. Remember the tissue around the kidney, that fatty tissue that I told you about? Cancer may also be extending up to that portion. But here's the Gerota's fascia. It's within Gerota's fascia. It has not gone through Gerota's fascia. Okay, that's the key. Whereas a stage 4 means either the cancer spread to another area of the body, either through the lymphatic system, it traveled and it went somewhere distant, like for example, bone, brain, lung, liver, or through our blood vessels, it spread to another area of the body, or locally it penetrated and went through Gerota's fascia. And that's why it's so important that you know about Gerota's fascia, because if the cancer has gone through that membrane, then it's also considered a stage 4. So I need you awake now. The most important question you are going to ask your doctor is, what stage cancer am I? You need to know, is it a stage 1, 2, 3, or 4? And keep that number in mind, because the treatment will vary depending on your stage. Okay, so let's move to the next slide. So genetic testing. The question is, were you born with a gene that predisposes you to genetic testing? It's what we call germline testing, okay? And overall, if you have kidney cancer and you are younger than 46 years of age, or 46 or younger, you can consider genetic testing. Same thing as if you have a strong family history. For me, if you have one first-degree relative with a kidney cancer, and now you have a kidney cancer also, you have to strongly consider genetic testing. Also, if you have a patient with multiple kidney cancers, for example, maybe you have one in your right kidney or left kidney, or you had 2 kidney cancers at the same time, or maybe you had kidney cancer a few years ago and now you have another kidney cancer. This would be another consideration to obtain genetic testing. So a question that I would ask is, do I need genetic testing? Okay, and consider asking that to your doctor. All right, so now let's move on to diagnosis. So in general, in most other cancers, when we have a mass and we're suspecting cancer, we do a biopsy. What I want you to know for kidney cancer is that usually we do not obtain a biopsy, okay? A lot of times, if the radiologist tells us that it looks like a cancer on the CT scan or the MRI scan, usually we take it out. Unless, I'm going to give you one instance where we might do a biopsy. Let's say you have a kidney mass and you have metastatic disease, meaning it looks like the cancer has spread to another area of the body, then why take out the kidney mass, okay? So in those instances, we might do a biopsy. I just wanted you to know that. So question that I would have for my doctor is, do I need a biopsy, or are we going to just proceed straight to surgery? And we're going to cover this in a lot more detail when we get into surgery for kidney cancer. So let's talk about the different types of renal cell carcinoma. And I'm using the terms interchangeably, kidney cancer and renal cell carcinoma. So if you have had surgery done or a biopsy and you have your pathology result, I recommend you find it so you can follow along with me, okay? So just know the only way that you're gonna know what type of kidney cancer you have is if you've had surgery or a biopsy, okay? You cannot determine this based on a CT scan or an MRI. For this, you need actual tissue, all right? So by far, the most common type of kidney cancer is clear cell carcinoma. That's about 75% of cases, okay? The next most common is called papillary, and it's about 15% of cases. And then we have another one that's called chromophobe, and that's about 5% of cases, okay? And these we usually call non-clear cell renal cell carcinoma. So these are just terms that I want you to become familiar with, because the most important thing here is that about 75% are clear cell carcinoma. And the reason this is important is because most clinical trials, most studies are done on patients with the most common type of kidney cancer, which is renal cell carcinoma. So most of the data that we have comes from clear cell carcinoma, okay? That's why I really want you to know about this. Now, there are some rare, very rare types of kidney cancer. One of them is called collecting duct carcinoma. Another one is called renal medullary carcinoma. The only reason I'm mentioning these two, because out of the rare ones, these are the most common ones. But again, very rare, less than 1% of cases. And the reason is these are treated differently. So when we get into treatment, if you have one of these, then this does not pertain to you. Now, if you have a non-clear cell, one of these, the papillary or the chromophobe, there are some differences, especially when it comes to the medication part, the immunotherapy, chemotherapy, etc. But for the most part, the top three are pretty much treated the same, okay? Some minor differences, but the collecting duct and the medullary, totally different. So the other term that I want you to become familiar with is the word sarcomatoid or rhabdoid, okay? So I wrote them here. If your pathology result is using these words, it just means that, unfortunately, the cancer you have is a little bit more aggressive. And that's what the take-home message here. You need to know this because, you know, if it looks like you have a more aggressive variant, then we're going to be more aggressive treating you, okay? And that's the reason you need to know this. So the questions that I would ask here is, what type of renal cell carcinoma do I have? And do I have a sarcomatoid or rhabdoid feature? All right? Those are the questions that you need answered. All right, so before we continue, I'm going to ask you for a little favor, and that is, if this video is helping you, subscribe, like, and most importantly, share the video, because you never know who else can benefit from watching this video. So let's move on. All right, now I just wanted to let you know what doctors will you follow with if you have a renal cell carcinoma. And it's basically two. Number one is a urologist. Those are the ones that would perform the surgery. And number two is a hematologist oncologist or a medical oncologist. That, for example, is me. And we're the ones that provide you with all the medication portion, the immunotherapy, chemotherapy, etc. All right? All right, now I want to go over something that we call risk stratifying the patient. And for the most part, these are blood tests that we can look at that will tell us, do we think your cancer is going to behave aggressively, putting you at high risk, or maybe not so aggressively? It's going to grow slower, placing you at a lower risk or low risk, all right? And overall, the first one is not a blood test, and it's called a poor performance status. And this just means if you are a patient that is older, more debilitated, maybe you are wheelchair bound, obviously we are not going to be able to be very aggressive with you, and that is not a good thing. So it's what we call a poor PS, known as performance status. So if you're very weak, very frail, very debilitated, that is not a good thing, placing you at a higher risk. If your LDH, this is a blood test, if your LDH is high, okay, that's a risk factor. If your blood calcium level is elevated, that's another risk factor. If you have anemia, meaning your red blood cells are low, that's another risk factor. And if you look at your white blood cells and you look down at your different types of white blood cells, okay, this is all on your CBC, you will find a cell called a neutrophil. And if your neutrophils are elevated, that's another risk factor. And last but not least are your platelets. If you look at your platelet count and they are elevated, that's another risk factor. So the way to know is pause the video now, find your blood test, and look for these labs. And if you have not had some of these labs performed, then tell your doctor to test you for them. But I can tell you, for the most part, chances are you've had these labs done, okay? And the more of these you have, the higher risk you are. And remember these, because when we come to the treatment portion of this, I'm going to refer back to this, okay? So you need to know this. So the question is, as far as high risk and low risk, where do you fall? Are you considered high risk or low risk? And you can either figure this out on your own or ask your doctor. Right, so on this slide, I'm going to tell you all the different treatment options available for renal cell carcinoma. And then on the subsequent slides, we're going to break them down one by one, okay? So the first treatment option is do nothing. That's right. Sometimes in renal cell carcinoma, depending the stage and depending the patient, we might opt to do nothing and simply observe. We're going to go over this. The next one is surgery. Either we take it out or ablation. We burn it or we freeze it with a catheter. We're going to go over that as well. Another option are medications, and there's many different medication options, okay? You have oral medications called TKI. The TKI stands for tyrosine kinase inhibitors, and there's many of them. And again, we're going to go over all of these. The other treatment option in the medication arm is immunotherapy. We also have monoclonal antibodies, and we have other options as well, okay? So now let's break these down one by one. Now in this slide, we are going to go over surgery, and I want you to pay attention, especially if you have not yet had surgery for your kidney mass, okay? The first thing I want you to know is that most of these surgeries are done minimally invasive using a robot, okay? And the neat thing about this is that your doctor will perform this surgery using small incisions, and the recovery time, the time tends to be a lot less. In the old days, they had to perform this surgery using a large incisions, and patients took a long time to recover. I have to tell you, when my patients go for surgery, I am pleasantly surprised on how well they do, how quickly they recover from surgery, okay? That's, for the most part, that's what we see. Now, what I want you to keep in mind here is that the surgeon, the urologist, has two options. They can either do what they call a partial nephrectomy, where they remove part of your kidney, or a total nephrectomy, where they remove your whole kidney. And as a general rule, if possible, we much prefer that they remove part of your kidney, okay? So partial nephrectomy is the way to go if possible. And there are many reasons for this, okay? But I'm going to give you one, just so you keep in mind. And this is not to scare you. This is just, I want you to learn. That's the purpose you're watching this video, okay? And that is that patients whom have had kidney cancer have about a 5% chance, lifetime risk, okay, this is throughout your life, 5% chance of developing kidney cancer in your opposite kidney, your contralateral kidney. And why is this important? Think about it. If they removed your whole kidney and now you have a new cancer years down the line on your other kidney, then you might end up on dialysis if they have to remove your whole kidney. So that's one of the reasons that, if possible, try to push for a partial nephrectomy if possible. Like I said, sometimes you might not be a candidate. Sometimes your doctor has to perform a total nephrectomy. So the question that I would ask is, am I a candidate for a partial nephrectomy? All right, now let's get into medications. And I want to tell you, there's a lot of medication options that we can use in renal cell carcinoma. And you don't need to memorize these. I'm just going over this so that you know that there's a lot of options, so that you have that in the back of your head. Now, remember, I'm going to go over this, and then after these two slides, we're going to break them down by stage. How do we treat each individual stage? So stay with me. The first thing is a group of medications that we call TKIs. TKI stands for tyrosine kinase inhibitors. They're oral therapy, and there are many. For example, sorafenib, sunitinib, pazopanib, axitinib, lenvatinib, cabozantinib. I mean, there's a bunch of them, okay? As you know, in general, most of them have very similar side effects. You know, some may have their particular side effect here or there, but overall, rash, mouth sores, diarrhea, weakness, decreased appetite. These are all potential side effects that these medications can give you, okay? Keep that in mind, and let's move on. All right, now moving on to other medications, okay? We have a family of medications called immunotherapy, and as the name implies, these are medications that boost your immune system to try to fight off the cancer cells. And just know that most of these are given intravenously, and there's many options as well. For example, pembrolizumab, avelumab, nivolumab. We have a combination of nivolumab with ipilimumab. And just know that overall, these medications boost your immune system, but in doing so, your immune system may cause inflammation. So for example, if it causes inflammation in your lungs, it can cause a pneumonitis, and that can cause a lot of coughing. If it causes inflammation in your colon, it can cause a colitis, resulting in a lot of diarrhea. And again, it can cause inflammation in multiple organs. The good news is that, number one, it's rare. Overall, we don't see this quite often. And number two, even if you develop it and we find it early, we can stop the immunotherapy, and then we'll start you on a family of medications called steroids, which are just strong anti-inflammatory drugs. And for the most part, most patients recover well, okay? So let's move on. Right, another option your doctor can have is giving you a combination of drugs. So for example, we can give you a combination of TKI, the pills, together with immunotherapy in the vein. So there's many combinations available, like axitinib with pembrolizumab, or cabozantinib with nivolumab, lenvatinib with pembrolizumab. Many options, okay? And just know that this is likely to work a little better because you're receiving a combo, but you're also more likely to develop side effects. It's common sense. you're getting more medication, so higher risk of side effects, okay? Just know that there are also other options, belzutifan, bevacizumab, interferon alpha, temsirolimus, everolimus, many different options. And the reason I'm presenting this to you is that I want you to always keep in mind that there is not one combination. You have many options out there depending your individual needs. And that's why you need to know this and have that important conversation with your doctor. All right, now let's get into treatment. Okay, and the first question, believe it or not, that you want answered is, do you need to be treated in the first place? That's right, sometimes you may not need treatment, okay? And let me give you some examples here. Let's say you are older age. You're a patient that is older. Maybe you have heart failure. You have other medical issues. And maybe your tumor is very small in the kidney. Maybe, you have, remember when we went into the low risk and high risk that I told you we were going to go over again? Maybe you're lower risk. Remember, maybe you don't have anemia. Maybe your neutrophils are fine. Maybe your platelets are normal. In these cases, we may opt to observe, because why treat you if it's not absolutely necessary? Now, obviously, if you have a lot of cancer, if you're younger, if you're higher risk, if we think the tumor is growing fast, then obviously treatment would be the way to go. But ask your doctor either way, do you really need treatment? Especially if you're older, more frail, that would be a question to ask. If the answer is no, you do not need treatment, then surveillance, leave you alone. We will monitor you. We will perform scans from time to time, and we'll get a better idea as to how the tumor is behaving. Sometimes these tumors do not grow fast. Sometimes they take a long time to grow, so why treat you if that's the case? Now, if we see that it's growing fast, then obviously we may need to treat you. And if you ask the question, do I need treatment? And the answer is yes, then obviously we're going to start treatment, okay? So the question, as I already told you, is do you need treatment in the first place, all right? All right, now let's break down treatment by stage. And I'm going to say this very slowly so that you can follow me, okay? Remember, you asked your doctor, what stage cancer do you have? And then now you're going to take that stage and you're going to apply it here. If you're a stage 1, usually what the doctor will do is surgery and you're done, okay? Hopefully a partial nephrectomy if possible, and you're done, and then they will just monitor you, okay? Now, if your tumor is very small, usually less than 3 centimeters, they can also consider performing a procedure that's called an ablation, and that's, they'll put a catheter in there, and they'll either burn it or freeze it, okay? And by burning it or freezing it, hopefully they can kill it. Now, there's 2 things that I want you to know here if they opt for an ablation. Number 1, an ablation really only works if the tumor is small, usually less than 3 centimeters. If it's greater than 3 centimeters, an ablation might not be the best option. And number 2, remember I told you that most of these tumors, we do not biopsy. So they may do an ablation, and how do we know if it's an actual renal cell carcinoma? Well, if they're going to put a catheter there in the first place, you're already going to have a catheter there, well, they should try to obtain a biopsy before they do the ablation. So ask that question. So if you're a stage 1, surgery or ablation, and if they do an ablation, it's because it's a small tumor, and make sure they do a biopsy if possible. And if you go for surgery, try to, ask about a partial nephrectomy, okay? Now let's talk about stage 2 or stage 3. Again, surgery is the way to go. If possible, partial nephrectomy. But in stage 2 and stage 3, the chances of the cancer coming back are a little bit higher, especially stage 3. So the question is, can we give you a medication to try to prevent this cancer from coming back? And the answer is yes. We can give you immunotherapy. The more commonly used one is called pembrolizumab. So the question that you have to ask your doctor is, if you have stage 2 and stage 3 and you had surgery, are you a candidate, or are they considering giving you immunotherapy? If, as a general rule, if you are higher risk, let's say your tumor was invading blood vessels or regional local lymph nodes, Or remember sarcomatoid from the beginning, you have sarcomatoid features. Or when we went over high risk versus low risk, maybe you have a high LDH, anemia, high neutrophils, high platelets. You know, the more of these you have, your doctor can put all of this together and tell you, you know what? I think that giving you some immunotherapy might be the way to go. So the question here is, do they recommend immunotherapy in your case? All right. And I put the word adjuvant here. Adjuvant simply means after surgery. So giving you treatment after surgery to try to prevent the cancer from coming back. All right. So let's go on to stage 4 disease. Right, so when it comes to stage 4 disease, we have many options. And the first question, once again, is do you need treatment, okay? That also applies to stage 4 disease. And if the answer is yes, then there are many different options. We can give you the TKIs, remember the oral pills, or we can give you the immunotherapy, or we can give you the combination. So the way we usually approach this is if you're strong enough to tolerate aggressive treatment, or if you have higher risk disease, then we're more likely to give you the combination. In other words, the TKI together with the immunotherapy. Now, if you're weaker, maybe you're a little more debilitated, you're older age, we're afraid of the side effects, then we may treat you with monotherapy, meaning one or the other, okay? Either a TKI or the immunotherapy. And that's pretty much the way that we treat this. So what happens is, question that I commonly get is, if I have metastatic disease, for how long am I going to be on treatment for? And overall, it's usually for the rest of your life, because think about it. If you have cancer that we cannot cure, if we stop treatment, the disease is just going to grow back. So we usually continue until what we call disease progression, meaning we are giving you these medications, and unfortunately, with time, the disease develops resistance to the treatment and it starts to grow. And in that case, we switch treatment. Or intolerable side effects. Let's say we're giving you these medications and 6 months down the line, whatever, a year down the line, you're just getting a lot of side effects because you've been on this drug for such a long time, then we may also switch treatment. And that's pretty much the way we treat metastatic disease. Right, and the last slide is monitoring. So you've had treatment. How do we follow you? Well, overall, if you're a stage 1 or a stage 2, so you already had surgery, and maybe for stage 2, they gave you immunotherapy afterwards. We usually perform laboratory studies and a CT scan or an MRI scan every 6 months for up to 5 years. Now, I can tell you for stage 1 disease, as time goes on, especially after the 2nd year, we may perform a scan once a year. For stage 2, we may perform a scan every 6 months for 2-3 years maybe, and then after that, once a year. It really all depends. What is the likely chance, or what we believe are your chances of this cancer coming back? Because remember, the CT scans, for example, do give off a little bit of radiation. So we want to try to avoid excess scans if possible. Stage 3, again, we do laboratory studies, and then we will perform CT scans or MRI scans every 3 to 6 months, usually for the first 2 years, and then 2 to 3 years, and then maybe yearly after that, to complete 5 years of monitoring. It's very rare for a kidney cancer to come back after 5 years, okay? So that would be the good thing. And overall, patients ask me, after 5 years, yes, we consider you cured for the most part. Stage 4 disease is different, because think about it. In stage 4 disease, you have uncurable disease. We're giving you treatment. We're trying to keep that disease from growing. We're trying to shrink it up. So every so often, we have to perform a CT scan or an MRI scan to see if the disease is shrinking or is it growing. Because if it's growing, obviously we have to change treatment. So overall, we will perform an imaging test every 2 to 4 months, give or take. And we will also perform labs depending on the treatment you're receiving. There we want to monitor your thyroid, your kidney function, your liver function, your CBC, just to make sure we can continue giving you chemotherapy and you're not developing any unwanted blood side effects, okay? So thank you for your attention. I really hope you found this valuable. If you did, share the video, consider subscribing in my channel. I have videos on multiple different types of cancers with the same approach. I try to make it simple, easy to follow, and they're all dedicated to you, patients, family, and also anybody who wants to learn. Thank you.